Hello everyone. So this is the last video of the series of chest X-ray basics for mainly targeted for the undergraduates. So if you have not watched all the previous videos, please do watch it. So we have discussed about how to interpret a normal X-ray. Then we have talked about the pleural effusion and also about consolidation, pneumonia. We have discussed everything. These are the commonly asked X-rays in the exam, and we have known about the Silhouette sign, bronchopneumonia, everything we've discussed, collapse, right? So everything we have seen, and also pneumothorax and something about pulmonary TB, very commonly asked in the exams. And definitely now this the last video will be a bit about miscellaneous X-rays. So this is where we start from today. So this is an X-ray again. So let us discuss this. Right. So what do you see in this X-ray? The trachea is somewhat deviated to the right. Can you appreciate that? And have you noticed that there are diffuse, patchy, reticular-like opacities everywhere in the bilateral lung field? So why it is a reticular opacity? And why not alveolar? Because they are having some thick and sharp margin, unlike fluffy cotton wool like opacities in case of alveolar opacity. So these are thicker, relatively thicker reticular opacity, as I would describe that on a chest x-ray, mainly reticular. Some part of it is nodular, and trachea is shifted to this side. So this is interstitial opacity definitely, and probably this is a case of pulmonary fibrosis. So why did I say it probably? Because these findings of interstitial opacity are better appreciated on HRCT of the thorax. It is not well characterized on the X-ray because a reticular opacity can not only be fibrosis, it can be edema, it can be lymphatic obstruction, it can be many other things, because in the interstitium there is not only your fibrous tissue, there are veins, there are your lymphatics, everything is there in your interstitium. In case you're wondering what is the interstitium, these are the alveoli, alveolar sacs, and in between whatever is there is your this very part is the interstitial area. Everything that is marked in blue is the interstitial area, right? So this will contain your fibrous tissue, this will contain your veins, your lymphatics. So any pathology in this area will manifest as your reticular opacities, like that. You can see that thickened reticular opacity in bilateral lung field. So the next thing you would do is a HRCT of the thorax. So it is a case of pulmonary fibrosis, right? This is another X-ray. This is also having coarse marking in bilateral lung fields. This is more of nodule, and some part is also reticular thickening. So this is reticulo-nodular opacities in bilateral lung field. This is how we describe the X-ray. Definitely there is loss of lung volume in bilateral field, because these are changes you see in diseases that cause volume restriction, that is restrictive lung disease. You have two kinds of lung disease: obstructive and restrictive. In the restrictive one, there is volume loss, because of fibrosis. So this is reticulonodular opacities diffusely in bilateral lung field. So this is also a case of pulmonary fibrosis. Now, whether it is because of your connective tissue disease or it is an idiopathic pulmonary fibrosis, can be very much characterized on HRCT thorax. So the question that will be asked is, what is the next step on investigation? So you will be writing that we will be seeing a HRCT thorax, right? So there are three kinds of opacities, which is reticular, nodular, and reticulonodular. This is the most common thing that we appreciate on a chest X-ray. So it is too many lines, that is reticular. You can see that there are too many lines here, thickened, sharp lines in bilateral lung field. And mind you, these are predominantly in the lower zones of the lung, bilaterally symmetrical. So this can be due to a connective tissue disorder, right? So let me just go back to the slide where I have discussed that. You can see that the upper zone predominant fibrosis is the differential diagnosis of TB, Angst not to forget. And in the lower zone, if it is bilaterally symmetrical, think of connective tissue disease. So these are the usual things. Don't first say asbestosis and drugs. The connective tissue disorders you will be appreciating on the lower zones initially. Later on, everything will be involved. Now, now let us see how. This is the nodular variety. So you will see that there are multiple nodules, but mind you, these nodules are bigger than 3 mm. The size is not important, but the visual impression, you can see that these are not like your miliary TB X-ray. They are slightly bigger. They are slightly bigger, right? So this is nodular thickening, and this is reticulonodular, which is a mixture of the two. So this is once again showing you the miliary TB X-ray. These are also nodules, but these are very tiny 1 to 3 mm nodules scattered throughout the lung. This is miliary TB, right? So this was few words about the interstitial opacities. So these are not well characterized by your chest X-ray, but definitely you will be going for HRCT thorax. Now let us see few things about the cardiogenic versus a non-cardiogenic pulmonary edema. So anytime I speak about or anyone says about non-cardiogenic pulmonary edema, it is synonymous for ARDS, right? So in cardiogenic pulmonary edema, it is predominantly the heart that is involved, as the name implies. So there will be a heart failure or a cardiomyopathy, whatever it is. So it is cardiogenic mostly, and since it is cardiogenic, so the cardiac size will be typically enlarged. Here it will be normal. It might be enlarged also because there can be underlying heart disease. So ARDS is seen in severe sepsis, in pancreatitis, in burns, right? These are the important causes. Pancreatitis, so you have to take the history also. Severe sepsis, burns, a patient can have underlying heart disease also. So the patient is very sick in ARDS, and the distribution of the opacities is relatively homogeneous in case of cardiogenic. In cardiogenic, the typical thing to notice is in bilateral lung field, there is bat wing opacity, opacities like fluffy opacities near the hilum, right? Near the hilum, you will be noticing the opacities. That is bat wing opacity. This is not specific for cardiogenic pulmonary edema, but it is typically commonly very much seen. And air bronchograms are seen in ARDS, and the distribution of the opacities are diffuse and patchy. Another important thing to note is, since it is a heart failure, there is hydrostatic pressure everywhere. So there will be bilateral pleural effusion and curly B lines, which are if you zoom in the X-ray or if you notice very closely, there will be some perpendicular lines which are interstitial edema seen from the periphery like this. Very minute, thin opacities. These are your curly B lines. The opacities will be predominantly the around the hilum. So this is a bat wing opacities. There will be pulmonary, there will be pleural effusion. So note the angle blunting, right? So and the heart size will be bigger. That is cardiomegaly. These are the features of your cardiogenic pulmonary edema, right? So here will be the opacities. So we will be seeing images, right? So this is the animated image. You can see that the pulmonary edema is mostly around the hilum. So that is the bat wing opacity. The heart size is increased. How do we know that? So you take the maximum diameter of the heart on the right side from midline and the maximum diameter on the heart on the left side. You add this two, right? This is A and this is B, and this is your thoracic diameter. That is the maximum thoracic diameter. So A plus B by, let's say, C should be more than 0.5 for to call it as a cardiomegaly. So typically it is a visual impression. You don't have to measure it with a scale. And so this is, and you can see that these are the curly line. This is an annotated image. So this is typically seen at the periphery of the lung, curly B lines. So curly B lines, pulmonary edema, heart size, pleural effusion, bilateral. It is a systemic cause. Hydrostatic pressure is increased, and there is another finding is redistribution of the venous flow at the upper zone. Upper zone vessels are very much congested in the initial stage, right? So these are the important findings. Now let us see the X-ray. So this is a typical X-ray of heart failure. You can see that there are bilateral perihilar congestion in the form of a bat wing opacity, right? Pleural effusion can be if there is no pleural effusion or there is mild pleural effusion, the angles are blunt, and you cannot much comment upon the heart size, but it seems to be increased because mostly these patients are also sick, and if taken in an AP view you cannot comment much. The view is usually written somewhere here in the X-ray, but anyway there are bilateral hilar congestion. The heart size seems to be increased if not taken in an AP view. Then we can comment on that. Now let us see other X-rays also. This is a classical example of pulmonary edema due to heart failure. How do I know that? Because the angles cannot be seen, so there is bilateral pleural effusion. The heart size is definitely it is increased, not visualized because of these opacities bilaterally, and there is hilar congestion also. And if you zoom it, there will be some upper zone predominant dilatation of the vessels in the early stage. This is another X-ray. Typically at the hilar region you have congestion, you have the pleural fluid, bilateral pleural effusion, the heart size is increased. Definitely these all are X-rays of pulmonary edema, and you add a word behind pulmonary edema, that is cardiogenic pulmonary edema, right? So this is definitely you will be asked regarding the treatment and everything. So that is all about cardiogenic pulmonary edema. Now this is a miscellaneous X-ray. Can you say this is definitely not cardiogenic pulmonary edema? But what do you notice here in this X-ray? The heart is normal, angles are clear, trachea is in the midline. But look at the hilum. The hilar area seems to be full bilaterally. Bilateral fullness of hilar area. So bilateral hilar enlargement. It can be due to the anatomical structures at the area of the hilum. So supposedly, if I tell you that this is a 30-year-old male, 30-year-old male who is complaining of dyspnea, right? Who is complaining of dyspnea and maybe some dry cough, right? For let's say past 3 months, and you are finding erythema nodosum on the shin. So this, what do you make of it? If you are saying something like sarcoidosis, you are probably right. So in India, if you are finding unilateral hilar lymphadenopathy, think of TB. But if it is bilateral hilar lymphadenopathy, so always consider sarcoidosis in the first differential diagnosis. Of course, there can be many other diagnoses, but sarcoidosis, it is stage 1 sarcoid which presents with bilateral hilar lymphadenopathy. Bilateral hilar lymphadenopathy. Right. So this is bilateral hilar lymphadenopathy in sarcoidosis. Can be asked in the exams. Now let us go back again to this X-ray, which is sort of confusing with the heart failure X-ray. but it is not heart failure, because you can see that the air bronchogram sign can be seen everywhere in the X-ray. Although they are having a hilar congestion, but also it is extending up to the lower zone in both the lungs, mid zone and the lower zone. So if I say that this patient is admitted in the ICU, has suffered from severe pancreatitis, and he is on, see, you can see the tubes also. He is having endotracheal tube. There are multiple lines. This patient is very much sick, and so you can make it that this is a diagnosis of ARDS. Usually the patient is very sick, supine X-ray has been taken. It is usually AP view, like I said in my first video. So you can not really comment upon the heart size, but anyway, there are air bronchogram sign, diffusely opacified lung on both sides, in the background of severe sepsis, right? In the background of severe sepsis, ICU patient, all these are catch points for your ARDS, right? So usually not asked in the exam. However, these X-rays are very important, sarcoidosis, and this is that of heart failure, very important for exams. Right. So another important X-ray that can be a differential diagnosis of your cardiomegaly is this very X-ray. Anytime you see an enlarged enlarged heart shadow, what do you make of it? Whether it is really an enlarged heart, or maybe the heart size is normal, something is around the heart causing it to be an increase in size in the X-ray. So clearly the cardiothoracic ratio, we do not even need to measure it. It is very much enlarged in this case. Can you see that the heart border is very much smooth in this case, like a water bag appearance? So this is that classical X-ray of pericardial effusion. Pericardial effusion. And so this is an important differential diagnosis with your cardiomegaly. So this is an important differential diagnosis with your cardiomegaly. So this is a case of pericardial effusion. How do I know that? There is definitely increased cardiothoracic ratio, and the heart borders are very much smooth. This border is very much smooth. Usually the heart border is not that much smooth. There is no pleural effusion, so you cannot think of cardiomegaly. There is no signs of heart failure also. So this is definitely a pericardial effusion. Important X-ray for the exams. Right. Now another important X-ray which might be asked in an exam is rather a very common case for your exam in your practical, also in your long case. So it is a young female, right? It is a young female who is having symptoms of uh, P&D orthopnea, right? Who is having a loud S1, who is having, are you guessing the disease by now? So who is having a mid diastolic rumbling type of murmur at the mitral area? So can you think that this X-ray is that of a mitral stenosis? If yes, you are right, because this can be asked in your exam. You see that this right heart border is very much prominent to the right side of the lung. It is not that prominent in our previous X-rays. And if you closely notice that there is another border seen, which is that of the left atrium. So the left atrium should be this, the at this point of the left heart border or the left mediastinal border, it should be like this. This is the aortic knuckle, this is the pulmonary bay, aortic knuckle, pulmonary bay, this is the that of the left atrium, and this is left ventricle. It should be like this. But can you see that there is the straightening of the heart border, and the right heart border has seemed to extend more on the right side. There is a double heart border, a double contour sign, double heart border seen. So this is a classical X-ray of mitral stenosis. Also note that there is upper lobe predominance of your pulmonary vessels, like I said, in pulmonary edema, cardiogenic pulmonary edema. So this, if you zoom it, you can see clearly upper zone predominant, and that is causing all the symptoms of PND, orthopnea, and all that thing. So this is always note for a straightened left heart border, upper zone predominant of pulmonary vessel, double heart sign, heart border sign. Now see, this is the annotated image. The heart border is straightened on the left side, straightening of the left heart border. This is the border of the left atrium. This is that of the right atrium, right? There is hilar congestion. There is upper zone predominant dilatation of the pulmonary veins, right? This is an X-ray. This is another X-ray. Can you see this artifact? And definitely these are these are evidence of your CABG, of your sternotomy operation, midline sternotomy. These are the surgical clippings that are being given in in this patient, because they have replaced the mitral valve. This is the typical location of your mitral valve. There is straightening of the left heart border, upper zone predominant congestion of the upper zone predominant dilatation of pulmonary vessels. There is double heart sign. Now this is very much evident in this X-ray. So all these are telling you that this is an X-ray of a mitral stenosis. Very important X-ray. Can you see that this is annotated image? This is the first mogul, which is aortic knuckle. This is that of the pulmonary bay. This is left atrial appendage, and this is the left ventricle, right? So these are the things that are seen and described on a X-ray. So the aortic knob, the pulmonary artery segment, dilated left atrial appendage, left ventricle, and the prominent pericardial fat. And this will appear as a straightened left heart border. Straightened left heart border because of this dilated left atrial appendage. So this is the third mogul. So it is also known as the third mogul sign. So dilated left heart border. So the straightened left heart border, double contour sign on this side, upper zone dilatation of pulmonary veins, and definitely with the clinical picture of fitting with that of mitral stenosis. This is the X-ray of mitral stenosis, right? So these are X-rays of mitral stenosis. Very important X-ray that can be asked in your long case viva also. And now finally, this will be probably our last X-ray in this series. So clearly this is also a common patient. Can you guess, just by looking at this X-ray, just the visual impression of it? This is an X-ray of, yes, if you are saying something like asthma, you are wrong. This is not an X-ray of asthma. This is an X-ray of, if you are saying emphysema, you are right. Because in asthma, they both are obstructive airway disease, that is your COPD and your asthma. In COPD, you have two types, chronic bronchitis and your emphysema. In emphysema, there is important thing is your air trapping. That is a very important concept of emphysema. Note that these lung field are very much elongated. They are hyperinflated, to be in the correct term. They are hyperinflated. The diaphragms are flattened. The heart is tubular. So how do I know that it is hyperinflated lung and not a normal lung? So this is also an X-ray of emphysema. So you count the ribs, right? How to count the ribs? We know that in the anterior ribs, it is around 7 anterior ribs and around 10 posterior ribs, not more than that. So let us count the ribs. So this is the first rib. Go from the front to the back, first rib. This is the second rib. This is the third rib, third anterior rib, fourth anterior rib, fifth anterior rib, sixth, seventh, eighth, ninth. So there are 9 anterior ribs when there should be visible only 7. And note the posterior ribs also. So this is the first rib, second, third, fourth. This is the method of rib counting. Second, third, fourth, fifth, sixth, 7, 8, 9, 10, 11. So again, so this is also 12th rib. So this is 11 to 12th rib seen in a PA view, and this is a hyperinflated lung field. Now we can call it as hyperinflated lung field. The diaphragms are also flattened. Because of air trapping, the lung field looks very much loosened as compared to our previous all X-rays. The heart is tubular. So this is an X-ray of your emphysema. In asthma, you will not get air trapping unless and until it is an acute attack of asthma. So you should not smoke, definitely, because that will cause this kind of lung. So we have discussed almost everything possible that are usually asked in your final year MBBS Viva. So that was it from my side. Thank you everyone.